Hello to everyone out there. Welcome to the UF Health Wellness University webinar about atrial fibrillation. I'm Marsha Mott, the coordinator for UF Health Wellness University. Thank you so much for joining us today. I'd like to introduce you to our speaker, Dr. Zubin Agarwal. Dr. Agarwal is a cardiologist at UF Health Cardiology at our Spring Hill location in Gainesville, Florida. Dr. Agarwal joined UF Health several years ago after completing a cardiovascular disease fellowship at the University of Miami and a cardiac electrophysiology fellowship at Harvard. He's done extensive research in cardiology, pulmonology, and critical care medicine. He's passionate about teaching cardiology rounds and creative writing. Dr. Agarwal has volunteered on medical mission trips in several places such as Malawi, Africa, Mexico, and the Dominican Republic. Dr. Agarwal also speaks 3 languages, including English, Hindi, and Spanish. During the talk today, if you have a question for Dr. Agarwal, you can submit written questions at any time using the Q&A button at the bottom of the screen. At the end of the presentation, I'll read your question anonymously. I'll only be accepting written questions and we'll try to get through as many as possible. Also, it's challenging to answer medication questions, so we'll do our best. But as you may be aware, it's hard to address medication issues without actually treating or seeing that patient. So be patient with us on some of those medication questions, and we'll do our best to answer as many as possible. Dr. Agarwal, I'm going to go ahead and turn it over to you now. Thank you so much.
Thank you so much. It's a pleasure to be here. Give me a second while I get set up, and I'll get started. Can you see my screen?
Yes, everything looks perfect.
Perfect. Thank you everyone for being here. It's a real pleasure to talk to you today. I'm going to talk about atrial fibrillation, and the title of my talk is Atrial Fibrillation, Getting to a Normal Rhythm. I would normally like to make this talk as interactive as possible, but I really do encourage you to ask questions. I'm going to leave plenty of time at the end for questions, and I'm hoping to get to as many of them as possible. And if I don't, please encourage you to leave questions at the end, and I'll try and answer them after the talk. So my name is Zubin Agarwal, and I'm been working at UF for a while now, and I'm really happy to be here. So atrial fibrillation, as the name sounds, is an arrhythmia of the heart, and specifically of the atria. So I'm going to take you on a little tour of Cardiac Anatomy 101. The heart consists of 4 chambers. 2 chambers are from the top and 2 chambers from the bottom. The 2 chambers at the top are called atria. The 2 chambers at the bottom are the ventricles. The atria are either right or left atria. And as you can see in this diagram, the right atria is here and the left atria is here. The 2 chambers at the bottom are the right ventricle and the left ventricle. This diagram was drawn by Frank Netter, who's one of the most famous cardiac anatomists of our time. To illustrate this point, I want to play this video, which I think shows how blood flows through the heart. So, as is shown here, there are 4 chambers of the heart. Again, the right and left atria and the right and left ventricles. And blood is pumped from the right side to the left side and then to the rest of the body. And in a fibrillating heart, blood flow is chaotic, and blood often doesn't flow smoothly from one side to the other side and can really stay in one place, and often forms clots either in the right side or the left side of the heart. And that can cause patients to feel very symptomatic if the blood isn't flowing through the heart into the rest of their body, and if the heart is beating so quickly that they simply aren't getting enough blood flow. A lot of patients ask me why they develop atrial fibrillation, and there often isn't one clear answer. But there can be a lot of reasonable explanations. The patients who have underlying heart disease are predisposed to developing atrial fibrillation. So as patients get older, they're more likely to develop atrial fibrillation. Patients who have an underlying cardiomyopathy or a weak heart are more likely to develop atrial fibrillation. And patients with congestive heart failure or blocked coronary arteries, such as coronary artery disease, are more likely to develop atrial fibrillation. Patients with high blood pressure or problems with their heart valves are more likely to develop atrial fibrillation. And then there are patients who have genetic abnormalities that are more likely to develop atrial fibrillation. And there's a lot of research in this area. I think that there's at least 20 to 30% of patients who have some genetic predisposition to develop atrial fibrillation, and we'll probably know a lot more in the next 5 to 10 years about which patients have some genetic determinants of atrial fibrillation. Finally, there are some extracardiac factors that can predispose patients to atrial fibrillation. Extracardiac factors just meaning anything outside of the heart that can predispose patients to atrial fibrillation. The most well-known extracardiac factor for atrial fibrillation is thyroid disease. So patients who have hyperthyroidism can develop atrial fibrillation. Patients with sleep apnea are known to have atrial fibrillation, and especially untreated sleep apnea. Patients who use alcohol or other drugs, especially stimulants, can develop atrial fibrillation. And patients who have a high autonomic tone, who have stressful jobs, can also develop atrial fibrillation. There are many ways to diagnose atrial fibrillation. Traditionally, atrial fibrillation was diagnosed by ECG, which is a 10-second recording that's obtained in the doctor's office. But now there are more sophisticated methods for diagnosing atrial fibrillation. Many of you have probably worn a Holter monitor, which is a 24-hour or 48-hour monitor for diagnosing atrial fibrillation. Now there are even longer monitors, which can be worn for up to 2 weeks or 4 weeks, that can diagnose atrial fibrillation or other arrhythmias. Some of you may have an Apple Watch, which can diagnose atrial fibrillation simply by looking at a tracing. There's been a development of a loop recorder, which is a subcutaneous chip that's the size of your thumbnail that can be implanted under your skin in a matter of minutes and lasts for up to 5 years, that can diagnose all sorts of arrhythmias. The technology is really quite extraordinary, and it's been incredibly helpful in making a diagnosis of atrial fibrillation in patients who otherwise would never have known about their diagnosis. And it's actually much more sophisticated than some of the recording systems that we have. So the ability to diagnose atrial fibrillation has really improved much more than it had when we simply only had the ECG. Before I go any further, I want to define a glossary of terms. There are many types of atrial fibrillation, and the way in which we manage atrial fibrillation really depends on the type of atrial fibrillation that you might have. There's a type of atrial fibrillation called paroxysmal atrial fibrillation, and that is a type of atrial fibrillation that comes and goes. So it might last for a few minutes to a few hours, and then it goes away on its own. So it's say kind of comes and then goes away, or it's on and off. And there's a type of atrial fibrillation that's persistent, so it lasts for hours to days or days to weeks, and it's managed differently, and it's associated with a different type of symptoms. Usually it's associated with fatigue, shortness of breath, or decreased energy. Finally, there's a type of atrial fibrillation that's long-standing and persistent atrial fibrillation. That's a type of atrial fibrillation that's also sometimes called chronic atrial fibrillation. Often those patients have been on medications or been cardioverted for atrial fibrillation, and they yet still remain in atrial fibrillation. So what are the treatment options for atrial fibrillation? Well, there are three primary treatment options. The first is cardioversion. A cardioversion is simply when a type of energy is applied to the heart to restore normal sinus rhythm. And that ultimately is the goal for many patients, is to bring you back to normal rhythm, to get you to normal rhythm. And I'll go into the specifics of the procedure of a cardioversion. But the idea is that we apply some energy to the chest and it gets the patient to normal rhythm. The second treatment option is medications. And there are a number of medications that can be used to treat atrial fibrillation. Some of the medications can slow your heart rate down, and some of the medications are used to restore normal rhythm. The third type of treatment option is an ablation. And this treatment option has been used for the last 15 years, and there's been a lot of new technologies that have been developed to bring this treatment option into the modern era, and it's become much more effective than it has been in the past. And I'll talk a little bit about what that treatment option entails at the end of the talk. On the bottom of the screen, you can see that a patient has a very fast and irregular heart rate in atrial fibrillation before a cardioversion, and after the cardioversion is applied, the patient has a very regular and slow heart rate. And that's ultimately the goal, is that once cardioversion energy is applied, the patient has a return to normal rhythm. So what is a cardioversion? Cardioversion is a procedure that occurs in the hospital. It's an outpatient procedure. The patient arrives in the lab, and the patient's often sedated for the procedure, and then the pads are applied to the front and the back of the chest. The patient is then after being sedated, is given some energy, which lasts for just a few seconds. After the energy goes through the body, the heart returns to normal rhythm. And the goal is that after the heart returns to normal rhythm, the patient's heart rhythm will stay normal for weeks to months, or hopefully longer than that. And after they wake up from the cardioversion procedure, they'll be able to go home the same day. Now, at this point, I want to open it up to the audience. Does anyone who enjoys gardening as much as I do know the name of this plant? I'll give you 30 seconds to respond. Is there any way we can see the answers? That's wonderful. So 73% answered foxglove, which is the correct answer. The foxglove plant is a very important plant in medicine. It was first discovered in 1930, and it's used to create digoxin, which is it's a very important medication for treatment of heart disease. So it was first discovered by Sidney Smith, and it acts in two ways. I'm going to discuss those ways. So at first, it acts by inhibiting the sodium and potassium pump, which increases the amount of calcium in the cells of the heart. And as everyone knows, calcium is important for muscle contraction. And so by increasing the amount of calcium, it increases the strength of muscle contraction of the heart. And it's used therefore to treat heart failure. But it acts in a second way by increasing the parasympathetic tone of the heart. By increasing the parasympathetic tone, it slows down conduction of the heart. And by slowing down conduction, it slows down the heart rate. And therefore, it can be effective in slowing down the heart rate in atrial fibrillation patients. And so it's been used more and more in treatment of atrial fibrillation. What's interesting about digoxin is that it has a narrow therapeutic window. So you can't give too little and you can't give too much. And for much of the 21st century, for much of the 20th century, patients would come in with digoxin toxicity and had to be treated for such. And so we started moving away from using digoxin for treatment of heart failure, but we still use it for treatment of atrial fibrillation because we don't need to use such high doses. And so many of you have probably still using digoxin for treatment of atrial fibrillation. And it's one of the oldest drugs available. And so I thought it was important to mention it. Okay, moving on. I want to talk about beta blockers next. Many of you are probably on beta blockers because beta blockers are used to treat so many things. Now, beta receptors exist almost everywhere in the body. Beta-1 receptors primarily affect the heart, whereas beta-2 receptors affect the lungs. And beta blockers block epinephrine and norepinephrine, which is part of the fight or flight response. So unlike digoxin, which accentuates the parasympathetic system, beta blockers block the sympathetic system. And beta receptors, like I said, are found on the heart muscles, the smooth muscles, the airways, the kidneys, and other tissues on the sympathetic system. First discovered in 1964, so they're just a little bit newer, but still they've been around for 60 years. And they were initially used for treatment of high blood pressure, and they still are, but now they're used for anxiety, for performance enhancement in sports, and for atrial fibrillation. And since this is to talk about atrial fibrillation, I'm going to talk about the beta blockers used for atrial fibrillation. Specifically, I want to talk about one beta blocker in particular, which is Sotolol. Sotolol is a very interesting beta blocker because it has many properties. It's a non-selective beta blocker, which means it works on many receptors, first synthesized in 1960, but not used widely in Europe until 1980, and not used in the US until later. Patients who take Sotolol can have side effects such as dizziness, fatigue, lightheadedness, weakness, shortness of breath, or slow heart rates, like other patients who take beta blockers. And so it's important that we use them carefully. But Sotolol is not just a beta blocker, but it's also an antiarrhythmic drug, which means it's a drug used to treat arrhythmias. Specifically, it's a class 3 antiarrhythmic drug, and there are 4 antiarrhythmic drug classes. A class 3 antiarrhythmic drug is a potassium channel blocking drug. And potassium channel blocking drugs cause QT prolongation. And what that is an EKG change that causes a longer interval on the EKG that can cause life-threatening arrhythmias called torsade de pointe, which is a French term meaning twisting of the points. I don't know why we kept the French term and not calling it just twisting of the points, but that's the word we use in the hospital. I'm going to take you on a little bit of a physiology lesson. If it's confusing, don't worry about it, but I just thought it'd be interesting to mention. As electrophysiologists, we study the cardiac action potential. This is the primary work that we do. And so Sotolol works on the action potential of the cardiac cells. And the way it works is by blocking the potassium channels. By blocking potassium channels, which prevents potassium from flowing back into the cardiac cells, it prolongs repolarization, which means it prevents the cardiac action potential from getting back to the baseline, from getting back to this state, which is the resting state of the cardiac cell. And by getting back to by prolonging this repolarization, by preventing it from getting back to its resting state, it prevents it from getting ready to go back to, from getting back to a point where it can act again, from getting back to a point where it can contract again. And so it slows down the heart rate in a way, which is kind of the point of treating atrial fibrillation, by preventing it from acting again or contracting again. It gets the heart to slow down, gets it to normal rhythm. But by prolonging repolarization, it also causes the QT interval to prolong, which is something we don't want to happen, because we don't want things to become so abnormal that can predispose you to arrhythmia. So it's a little bit of a push and pull, which is something that we always have to struggle with in medicine, is the push and pull, the risk of causing harm while giving you a benefit of the drug. And I think Sotolol in some ways is kind of a classic example of that. And there are other drugs in this class, and I'm going to talk about one other drug in the class as well as there's many other drugs that are class 1 or class 2 antiarrhythmics, and they also have similar kind of push and pull, and they act on different parts of this cardiac action potential. So I just thought it was a neat example of a beta blocker that has other properties. So amiodarone is the last drug I'm going to talk about. Amiodarone is another antiarrhythmic drug. It's a very, very, very commonly prescribed drug for atrial fibrillation, as well as for other arrhythmias. It was first discovered by a Russian physiologist while working in Cairo named Dr. Enrep. And the story of its discovery is interesting. It was discovered when one of his technicians was cured of chest pain while taking the extract of this plant called Kella. And the extract was called Kellin. And the plant is shown on the top right. And the extract was taken for all sorts of maladies. And when he noticed that this technician was cured of chest pain, he started isolating the extract. And then it was noted after that this technician started taking it that it also started curing arrhythmias, such as ventricular arrhythmias as well as atrial arrhythmias. And so it was synthesized in the lab and started being prescribed to patients. Unfortunately, it had a lot of toxicities, such as lung toxicities, liver toxicities, and thyroid toxicities, which are known right away. And the FDA didn't initially want to approve its use in patients because of these known toxicities. It's also an interesting drug because it's metabolized exclusively by the liver, and specifically by an enzyme called cytochrome P450-3A4. That's not necessarily important for you to know, except that it interacts with a lot of medications, including digoxin, which we've talked about, warfarin, which a lot of you probably have taken, phenytoin, and simvastatin. And its metabolite is DEA. So grapefruit is also not a medication. It's something that interacts with amiodarone, and so it's something that if you take, you have to be very careful that you balance the interactions of the medications and the things that you take with amiodarone. The half-life of amiodarone, the elimination half-life is 58 days. So if you stop taking it, half of the amiodarone will be out of your system in 58 days. So it's not like it goes out of your system right away. So amiodarone is a very interesting drug, and it's prescribed so often that we really have to know what we're doing when we prescribe it to patients. This last slide on this topic I want to bring up is stroke, the issue of strokes. And the reason I want to bring it up is that atrial fibrillation is associated with strokes. And as a provider who manages patients with atrial fibrillation, I have to always discuss the risk of stroke with them. So in patients who have atrial fibrillation, we have to evaluate them for their risk of stroke, and we take into account their other risk factors for stroke, which include high blood pressure, heart failure, diabetes, prior history of stroke, prior history of coronary disease, among other things. And taking those factors into account, I give them a recommendation as to whether they should be on an anticoagulant for stroke, such as warfarin or Eliquis, or one of the other drugs that we typically prescribe for stroke. And I'd be remiss if I didn't mention that stroke is such a common condition, and atrial fibrillation and stroke go hand in hand. And so we talk about stroke risk factors every time that we see patients with atrial fibrillation. Finally, I want to talk about catheter ablation. Catheter ablation is one of the newest treatments for atrial fibrillation, and it's appropriate in some patients who have very bothersome atrial fibrillation. The way catheter ablation works is it treats patients by targeting the hot spots for atrial fibrillation. The hot spots for atrial fibrillation are the points where the pulmonary veins meet the left atrium. And the way we approach that is by introducing catheters through the veins in the legs, bringing them to the heart, and then targeting the veins, the points where the veins meet the atrium in the left atrium. So who needs an atrial fibrillation ablation? Well, really anyone with documented atrial fibrillation for whom medical therapy does not work, which includes symptomatic, paroxysmal, or persistent atrial fibrillation resistant to medical therapy, symptomatic AF when medical therapy cannot be used or is not tolerated, or heart failure with AF whose symptoms cannot be controlled using medical therapy due to ineffectiveness or intolerance. And there are two types of catheter ablations on the market. The first is radiofrequency catheter ablation. This is a type of radiofrequency catheter. The catheters, as you can see, are very thin, flexible tubes. At the end of the tube is a 3.5 millimeter tip that delivers the energy to that spot, the hot spot, near the pulmonary veins. And by using a very targeted approach in an electroanatomical mapping system, we can target exactly where we want to go. The second type of approach is called a cryo ablation balloon. And unlike a radiofrequency catheter, it uses cold energy to literally freeze the tissue. It works in a similar way by using a catheter to deliver the freeze, but it really works just by freezing the tissue so that the hot spot goes cold. The technique is the same, but the energy delivered is different. So in conclusion, atrial fibrillation is common and it's associated with many bothersome symptoms. There are many approaches to the diagnosis and management of atrial fibrillation, and luckily for us, the diagnosis has become much more sophisticated now. Catheter ablation is one of the newest techniques in our arsenal and can provide symptomatic relief in carefully selected patients. With that, I'm going to open up the Zoom meeting for questions.
All right, I'm going to have you turn off your screen share, and I'm going to go ahead and ask some of the questions. We've got a lot of questions that have come in. So one of the questions we have was, I've been in permanent AFib for 5 years. Is there any chance of recovering?
That's a good question. So typically when we make a diagnosis of permanent AFib, we say that we've made a decision that there's no chance of bringing you back to a normal rhythm. So we say that our goal is really to manage your heart rate and not the heart rhythm anymore. So typically, no, we don't plan on bringing you back to a normal rhythm, but we do want to make sure that your symptoms are controlled by making sure your heart rate is controlled. And there are other approaches, like for example, if your symptoms are not controlled by controlling just your heart rate, we can provide an AV nodal ablation, which means that we'll sever the connection between the top chambers and the bottom chambers and and then we'll implant a pacemaker. And that's more of a definitive approach to atrial fibrillation ablation. And that's something that we could talk about, or you could talk to your cardiologist about if that's really something that you want to pursue in the future.
All right, I have several questions that kind of relate to things that you should maybe avoid when you're doing AFib. Can you talk about that, or any activities or foods that you should avoid?
Yeah, there's nothing that you really need to avoid. I mean, the hope is that you can live a normal life even if you have atrial fibrillation. I think that the important thing is that you avoid stimulants, because stimulants can exaggerate atrial fibrillation. But we want you to exercise, and we want you to be healthy. Certainly no foods that you need to avoid, but alcohol, I think, should be avoided. Smoking should be avoided, and stimulant drugs should be avoided. And then if you have sleep apnea, it's really important that you wear a CPAP machine at night. And then if you have thyroid disease or other medical issues, those should be well controlled. And I think those are the important points as far as managing your atrial fibrillation.
Can sneezing or indigestion trigger AFib?
It's very unlikely.
Okay. Couple of questions about that. What is the rate of stroke for people with AFib who don't take a blood thinner?
That's a very, very good question. It depends on your other risk factors for stroke. And there's been a lot of research on that question alone. So there's a score calculator we use. It's called the CHADS VASC score. It's spelled CHADS, VASC, VASC. And it's something you can look up on your own if you want to. A score of 2 means that you have a 2% risk of stroke. A score of 4 or higher means you have closer to a 6% risk of stroke without taking an anticoagulant. So that's a 6% annual risk. So I would say that you should take it, and anything above 2% means you should take a blood thinner or an anticoagulant.
Okay. What is the success rate of ablation for someone who has had AFib for a decade?
The success rate for an ablation for someone who's had AFib for a decade, I think it varies based on the type of AFib they've had and the person that they are. So it's hard to answer that question with any definitive number.
Sure.
The success rate for a person who's had AFib for a decade depends on if they've had paroxysmal atrial fibrillation or persistent atrial fibrillation. But for paroxysmal atrial fibrillation, I'd say that it's very, very good. Probably between 70 and 90%. For persistent atrial fibrillation, it's probably lower. Persistent meaning that they're always in atrial fibrillation. And I don't really know. I think that it really depends a lot on the individual person.
Okay. Someone asked, I'm 73 years old. My siblings don't have AFib, nor did my parents. So how did I get it?
Yeah, and again, that goes to the slide that I had earlier. Is a lot of people ask, why do I have atrial fibrillation? And it's so hard to answer that question because I don't have a reason why a lot of people have atrial fibrillation. And a lot of it is just because people have an aging heart, and as the heart ages, they have some sort of trigger that brings them into atrial fibrillation. Genetics only explains 20 to 30% of cases, and so I think there's like at least 75 to 80% of cases of atrial fibrillation that are not genetically related. And sleep apnea or thyroid diseases don't account for all of those cases. So I think that there's probably some intrinsic heart disease that explains the remainder of cases of atrial fibrillation. And we simply just don't have a good answer for why you in particular have atrial fibrillation yet.
Okay.
And I hope that someday in the future we'll have a better tool to diagnose why you developed it, but simply don't have that yet.
Okay. How do the treatments vary if someone has a pacemaker for bradycardia?
Oh, the treatments actually are much we have a much better way of treating atrial fibrillation if you have a pacemaker for bradycardia already. And the reason is that if you have a pacemaker for bradycardia, we can give you stronger medications without worrying about the side effects as much. A lot of the medications we give you can cause bradycardia. And so if you have a pacemaker for bradycardia, we don't have to worry about causing bradycardia because we know the pacemaker is going to pick up and protect you from the bradycardia. And so we can give you those medications without worrying about the side effects as much. And so that helps us treat your AFib a lot more aggressively.
Okay. Are you aware of any connection between AFib and PNH? Paroxysmal nocturnal hemoglobinuria?
That I'm not aware of.
Okay. And someone else asked, how does the information that you gathered from a cardiac CT, how is that helpful to you?
So we do a cardiac CT for planning for atrial fibrillation ablations. And the reason we do it is because the atrial fibrillation ablation is an ablation that targets the pulmonary veins. And the pulmonary veins are best visualized by cardiac CT. So when we do the cardiac CT, we can really assess where we need to go.
Okay. Do NSAIDs such as Tylenol or Advil reduce the effectiveness of Eliquis or AFib?
They don't reduce the effectiveness. In fact, they probably accentuate the effectiveness because the NSAIDs also cause thinning of the blood. And so we actually recommend you don't take NSAIDs such as Advil or naproxen while you're on Eliquis because we don't want your blood to be too thin.
Okay. I'm on Eliquis. I love grapefruit and green leafy vegetables. Should I avoid them completely or just eat sparingly?
So Eliquis doesn't interact with green leafy vegetables or grapefruit like warfarin does.
Oh, okay.
So you're welcome to take eat grapefruit and green leafy vegetables as much as you want.
All right. Let's see. How does ablation differ from the TAVR method, or are they even related?
They are not related. There are two different procedures, and they have a very different approach.
All right. Let's see. I'm back in AFib. I was taking Sotolol and my doctor said it wasn't working anymore and asked me to stop taking it, but they didn't shock my heart back into normal rhythm. Any thoughts on that?
Well, honestly, it's one of the struggles we have with atrial fibrillation treatment because a lot of those medications that we prescribe, like Sotolol, they work until they don't. And so atrial fibrillation, like many other diseases, is a progressive disease. So medications work for a period of time and then they don't. I don't really have a good reason for why your doctor chose not to shock you. My feeling is that it may have been because he felt like a shock would only work temporarily and then you would go back into atrial fibrillation. But it's probably worth asking him why specifically.
Okay. I have one person had their hand raised. I wanted them to type their question if they're able to do that for me, and then I'll get their question answered, by the way. So I have another question. I've had AFib diagnosed 2 years ago. How would I know if I still have it?
There are a couple ways. Most people will have symptoms if they still have atrial fibrillation. If you're worried, you could get an EKG to see if your heart rhythm is normal or if it's not. If you're still worried, you could wear a monitor, like one of the monitors I talked about, which you could wear for 2 weeks or 4 weeks. And if you're still worried, even after that, you could potentially get a loop recorder, which is a monitor I talked about, which we implant under the skin that lasts for 3 to 5 years. But really, for someone who's not having any symptoms at all, I don't think you need to go through the process of having a loop monitor implanted because that's a procedure that doesn't really make sense for someone who's not having symptoms.
Okay. With paroxysmal AFib, is treatment recommended, and how do you treat it when it happens so infrequently?
Well, it really depends on your symptoms. If you're having symptoms of paroxysmal AFib, that means if you're having palpitations, dizziness or lightheadedness, or shortness of breath, then certainly we would recommend treatment. And the treatment is either medications or catheter ablation. those are the only two treatments that we have on the market. And so if you're not having any symptoms, then there's really nothing that we need to necessarily do about it.
Okay, that's a good answer. 2 questions of things that contribute to AFib. AFib, can prednisone trigger AFib? And does neuropathy contribute to AFib?
Prednisone certainly can trigger AFib. It's like any other stress on the body, prednisone will make AFib worse. What's actually interesting is that a lot of patients who have atrial fibrillation also have lung disease, and patients who have lung disease take inhalers like albuterol, and albuterol can trigger AFib too, because albuterol is a stimulant like prednisone. So that can make AFib much worse. Neuropathy doesn't necessarily trigger AFib, but neuropathy can be very bothersome, and if you're really bothered by neuropathy, then that can make your AFib worse.
Okay. We're getting ready to have a talk on neuropathy pretty soon, so tune in for that one soon. I think it's at the end of February. Someone asked the question, what is vagal AFib? Is that a thing? I've never heard of that.
That is a thing, yeah. And that's AFib that's triggered by an increase in vagal tone. It's not commonly diagnosed, but it's something that's diagnosed when you're in the hospital and and your physician notices that your atrial fibrillation really only occurs by that process.
Okay. What percentage of the population has AFib, and does that change with age?
Yes, it really, the statistics vary, but they say that almost 1 in 8 people over the age of 80 will have atrial fibrillation.
Wow, that's a lot of people.
And it's probably even higher than that. It's probably actually closer to 1 in 4, and we simply just don't know about the other people that have atrial fibrillation. We just haven't diagnosed them yet.
Well, kind of along the lines of that, someone says, occasionally I feel like my heart is skipping a beat. Is that AFib? And can it happen when I'm just lying in bed, not doing anything physical?
It could really be any arrhythmia. I mean, it could be atrial fibrillation, or it could be any type of arrhythmia. Other common arrhythmias are PACs or PVCs. Those are premature beats or skipped heartbeats. And I think if you're worried about it, you can wear a monitor, like one of the monitors I talked about, and that'll make the diagnosis right away.
All right. Someone asked that I feel like I feel episodes of AFib, but I don't have other symptoms. I feel these, for instance, when I'm feeling them, I feel like I could still exercise. Is that still okay?
If you feel like you have episodes, but you have no other symptoms, you shouldn't go ahead and exercise. I don't think that should be a problem.
Okay. If an electrocardiogram shows you have leaky valves, are you apt to develop AFib?
So an echocardiogram would show you have leaky valves. And if your echocardiogram shows you have leaky valves, depending on where the leak is, you are apt to develop AFib. And depending on how big the leak is and where exactly the leak is, it potentially will happen in the future.
Okay. So I got a lot of questions about ablations. So some of them are, do you do ablations? How many do you do? And then afterwards, do you need to stay on a blood thinner?
Yes, I do ablations. I do many ablations, and you have to stay on a blood thinner at least for the rest of your, well, at least for a few months, but many people who get an ablation have to stay on a blood thinner for the rest of their life, but at least for 3 months, I would say, because patients who have AFib, they're, like I said, they're at high risk of stroke, and you typically don't want to stop the blood thinner just after the ablation, because the ablation is a procedure to reduce your AFib burden. There's a chance that it'll come back in some form at some point in your life. If it does, you would not want to be unprotected from that stroke risk. So.
Okay. Is there a particular situation where, I'm going to try to say this right, ticosine, and then they put in parentheses, dofiltiled is recommended as a treatment?
Yes, that's ticosine, which is the brand name for dofetilide. And is there particular situations for recommended? So Ticasin is the same class of medication as Sotolol. It's an antiarrhythmic drug. It's a very good antiarrhythmic drug, and it's one that I like using a lot. And as far as a particular situation where it's recommended, there are a lot of situations where it's recommended. It's used for paroxysmal as well as persistent atrial fibrillation. It has the same side effect profile as Sotolol, in that it can cause QT prolongation and arrhythmias if the QT gets too long. So it's also kind of one of those medications where it works until it doesn't. So sometimes it'll work, but as patients get more and more AFib, then it may stop working at some point. But it is a good drug, and it has to be used on a case-by-case basis. And so it's kind of hard to say exactly which situation where it'll work and where it won't work, but it certainly works in a lot of patients, and just kind of depends on which patient it'll work in.
Okay. Someone asked a question. Do you, you have to get your crystal ball out here. Do you ever think there will be a device that a patient can do their own finger stick to determine their INR level?
There are actually devices where patients can do their finger stick to determine their INR level. It's called a home monitor for INR. It's not completely accurate, but it's fairly good. My impression is that they're pretty expensive. I'm not sure if they're covered by insurance companies, but I do know that they exist, and I think if you're interested in getting one, you can talk to your INR lab or your INR clinic about getting it.
Okay.
That's it. I think that if you can, you should talk to your doctor about switching to one of the newer medications, which is Eliquis or Dabigatran, because those medications don't require INR monitoring, and they're much easier and I think much safer to take if you're a candidate for them.
Another question, do people who've had an ablation generally need more than one? Do they need another one maybe later on in their life?
That's a great question. It depends on the patient. Some patients have very complicated or complex AFib, and so yes, they do. Some patients don't, and they don't need more than one ablation. They're one and done. And so we always hope that their AFib is simple and straightforward, and they just have one ablation and they never have to come back. Some patients are just more complex and they need more than one. So it's never easy to predict which patients are going to be easy and which ones are not going to be so simple.
Okay. Someone asked a question about what I assume is maybe the mini maze, but they said, can you please comment on the procedure that Dr. Beaver and Dr. Miles do?
I can't comment on them. It'd probably be best to ask them about that procedure.
And you can reach either one of them through the same cardiology group and number that you work with. Am I correct?
Yes.
So we'll have that information for follow-up if you want to talk with them. I believe we also have some information on our website about that too. So we'll try to follow up about that. Let's see.
A lot of good questions today.
Yeah, it's hard to, that's why I keep looking at them, like trying to sort through them all. Let's see. Is occasional tachycardia treated the same as AFib? I'm sorry,
Say the first part again.
Non-sustained occasional tachycardia treated the same as AFib.
So I'm not sure exactly what non-sustained occasional tachycardia is. It could be non-sustained ventricular tachycardia or non-sustained atrial tachycardia, maybe.
I got to go with what they typed. I read it just.
There's atrial tachycardia and there's non-sustained ventricular tachycardia. They're treated differently, but atrial tachycardia and atrial fibrillation are very closely related, and they are treated similarly. Ventricular tachycardia is a different beast, and it's treated differently. Some of the medications are the same, but some of them are different.
Someone asked a really great question, honestly, and it's pretty basic. Can you have AFib and never feel it?
Yes, you can, and that's a great question. And I don't think we really understood that until recently in our field. But we say that 50% of patients who have AFib don't feel it. And I think that was a really big discovery for us as clinicians, because we relied on patients to really tell us when they were feeling AFib. And when we realized that many of them weren't actually feeling AFib 50% of the time, we realized we had to be a lot more aggressive in treating atrial fibrillation because they were having episodes that we didn't know about. And so, it's helpful to have more advanced monitoring techniques because we can detect AFib even when they don't feel it. But it's important because we want to make sure that we treat the AFib that they're not even feeling, because it can sometimes cause problems down the road, such as a weakened heart system, or it can cause strokes to happen even if they're not feeling the AFib. So yes, that's a very good question.
Okay. Does atrial fibrillation only appear on an EKG when you're active, or can you have a normal EKG one day and AFib the next day without many symptoms?
Yes, you can have a normal EKG one day and an AFib on an EKG the next day without any symptoms. That's the major problem with an EKG is it's a very short recording of your heart rate, and you can have an AFib even 10 seconds after the EKG is done and you wouldn't know it. And so that's why the EKG is not a great test for detecting atrial fibrillation. And we really look for better tests, such as a monitor or the Apple Watch even sometimes to look for atrial fibrillation.
Okay. Does changing positions rapidly or standing up quickly, could that trigger AFib, or is that just my imagination? Someone asked that.
No, that's not going to trigger atrial fibrillation.
Do you feel faint or nauseous when you have AFib?
It can happen, especially if your atrial fibrillation is causing very, very fast heart rates, but it's unlikely.
All right. When in your AFib journey, I like that it's a journey, would you consider ablation, or would you use radio frequency versus cryoablation? When would you?
Yeah, that's a good question. I think it depends on the individual patient. I think that it depends on how symptomatic you are. I think if you're very symptomatic, you would want to jump to an ablation sooner rather than later. And the reason for that is because AFib is a progressive disease, it's almost better to start sooner before it gets worse, because sometimes if it gets worse and we wait too long, it'd be harder to really successfully treat it with an ablation. And if we wait too long and we try medications for too long, maybe the ablation will be less effective in the future. The other question about cryo versus radio frequency is a very hotly debated topic, and there will never be a straight answer, I think. But the general consensus is that cryoablation is probably better to start with as a first-time tool, like as earlier in the journey, so to speak. And the radio frequency is better later in the journey. So I think that's generally the accepted kind of consensus when it comes to treatment of atrial fibrillation.
Okay. Someone asks about mitral valve repair and ablation. Are they done robotically? You know?
I can't speak to mitral valve repair since I don't perform those procedures, but I don't think the mitral valve repair is done robotically. Atrial fibrillation ablation is also not done robotically. We actually did talk about bringing a robotic system for atrial fibrillation ablation, and they do exist, but they're really not that helpful. It's not really that helpful to do atrial fibrillation ablation robotically because everything is done percutaneously as it is, which means that we do the procedures with catheters. So it's not that it's an open heart surgery, it's a catheter surgery, which means that it's minimally invasive. So robotic surgery wouldn't really mean much, wouldn't add much to a procedure since it's so minimally invasive to begin with. Mitral valve repair is also pretty minimally invasive, but it's certainly a much bigger procedure than an ablation procedure is. So I can't speak to that one.
Someone asks about their CHAD score. They have a CHAD score of 4, and they say that equates to about a 6% stroke risk without a blood thinner.
Yes.
Stroke risk when you take a blood thinner.
Sorry, say that again.
So they have a CHAD score of 4, and they
Yeah.
say that I guess equates to about a 6%
Risk, right.
without taking a blood thinner. If they add on a blood thinner,
What is their risk? Yeah.
how does that change that?
Yeah. We generally say it cuts their risk in half, but we don't know. It's not like we've really done a lot of research on their risk off blood or on their blood thinners. I would say that their risk is at least half of that, but probably even less than that. So I would say that your risk is at least 3% and maybe even less than that.
All right. If you have AFib without symptoms, take warfarin. What types of tests should you have, and how often should you see a cardiologist to make sure there's no other heart issues?
If you have AFib and you're on blood thinner, how often should you see a cardiologist?
Yeah.
I'd say that at least once a year if you're healthy. If you're having issues, then twice a year or more often.
Okay. I got a couple people who ask kind of like, my heart beats really loud and or I hear my heart beating. Is there any concern or risk for that?
I think if you're feeling okay, then just a loud heartbeat or your heart beating out of your chest is not a concern.
All right. Let's see. Can a glass of red wine trigger AFib?
Not often. I mean, I'm certain that something somewhere at some point a glass of red wine has triggered AFib, but it's not a common trigger.
Okay. And could you just answer this question? Why is calcium mainly in the left atrium? Is that?
It's not mainly in the left atrium. Calcium exists everywhere in the heart.
Okay. If someone has leg vein insufficiency, will wearing nylons or like a compression hose, will that help with AFib?
It won't help with AFib. It'll help with the vein insufficiency, and it's very important for vein insufficiency. But it has nothing to do with your AFib.
Okay. Someone says, I've been diagnosed with hyperthyroidism. They say that I have a high risk of developing AFib. Is this true? I think you've already covered that.
Yes,
but they want to radioactively kill my thyroid, and then I would be on Synthroid or another medicine for life. I don't want to do that. How would I know if I was developing AFib?
Well, I do think that it's important for you to have some treatment for hyperthyroidism. I think that's probably the correct approach, the radioactive treatment for your hyperthyroidism, precisely because of your risk for developing atrial fibrillation, but also because of the risk of the thyroid hormone can wreak havoc throughout your entire body and cause problems with your bones and with your liver and other organs. But as far as your AFib, I think you would notice if you went into AFib, you would have very fast heart rates, you'd feel sick to your stomach, you'd probably feel dizzy or lightheaded, and so you'd probably notice the atrial fibrillation once you went into it. It wouldn't be one of those cases where you'd have AFib and you wouldn't know about it.
All right. Someone wants to know, they said, I've had a type A aortic dissection. And am I at an increased risk for AFib?
That's a good question. You probably are at an increased risk of AFib, but it's not a clear-cut predisposition for AFib. But yes, I think you would be at an increased risk.
Okay. Could you talk about the Watchman procedure? I'm not sure what that is.
Yes, yeah. That's something we are also bringing to UF. So the Watchman procedure, for those of you who don't know, is a left atrial occlusion device, left atrial appendage occlusion device. And so the left atrial appendage is this tiny appendage that hangs off the left atrium. And it's kind of a vestigial anatomical thing that it's kind of like the appendix of the heart. And it's a small piece of the heart that can accumulate blood and cause clots to form. And so in patients who have AFib, that's where the clots form because it's small and the blood kind of accumulates there. And so the Watchman device is a device that we insert into the left atrial appendage that closes it off so that if blood accumulates there and clots form there, they don't travel outside of the appendage and to your brain. And so that's the purpose of it. And so patients with AFib who can't be on a blood thinner, we put a device there so that the clots don't form in the appendage, and well, clots will form in the appendage, but they don't go from there to the brain. So that's the rationale for putting the Watchman devices in. We ideally would just want to put patients on a blood thinner, but if for some reason they cannot be on the blood thinner because they have bleeding complications, or because they have an adverse reaction to the blood thinner medication, then we would put the Watchman device in.
Okay, apparently I got the question wrong about the calcium. So I apologize. So they were asking about cryoablation. Why is it done more in the left atrium
instead of the right atrium?
Yeah.
Yeah, that's a good question. Really, the reason it's done in the left atrium is because the triggers for AFib are found in the left atrium, and they're found in the junction of the pulmonary veins and the left atrium. And the reason we think that the triggers are there is because the pulmonary veins are made of the vasculature from the pulmonary system, whereas the left atrium is made of heart muscle. And so the juncture is really this kind of blending or meshing of the vasculature with the heart muscle. And so there's not this smooth connection. There's not like a cutoff where the vessels meet the heart muscle. It kind of blends together. And I think when the muscle fibers meet the vessels, they seem to interact with one another, and they form circuits where atrial fibrillation can form. So I think that's where the atrial fibrillation originates, and so that's why the left atrium is the source of the trigger for atrial fibrillation.
Okay.
That same kind of junction doesn't exist in the right atrium, because the blood vessels don't really connect in the same way in the right atrium.
Okay. Well, I thank you so much for your time. I know we have several questions that are holding out there, and I'll try to see if I can get those answered for the people who are still waiting for an answer. But Dr. Agarwal has patients very soon, so I want to let him have a chance to take a breath for a second and then go see his patients in a minute. Thank you guys so much for attending today, and thank you for your time, Dr. Agarwal.
Thank you so much. I appreciate it.